My name's Hampton Richards. I'm a practicing OBGYN in Dallas, Texas. I'm in private practice. For today's lecture, we're going to talk about estrogens, anti-estrogens, and then something called SERMs, or selective estrogen receptor modulators. These can be estrogenic in some tissue and anti-estrogenic in other tissues. So they're kind of a blend. We'll get into those. We're going to talk about estrogens both premenopause and postmenopause, and specifically with hormone replacement therapy, where estrogens are the primary molecule that are going to give us our effects and our benefits. So let's start with some basics and talk about the three different physiologic estrogens. There are three. When you're thinking about them, I want you to remember them by their signs, E1, E2, and E3. E1 is estrone. It's got the word 1 in it, which will make it easier to remember. This is the main circulating estrogen after menopause because it's not made by the ovaries themselves. It's made by peripheral conversion using aromatase enzyme by androstenedione, which is an androgen. Because of this, it sort of has a steady state throughout life. It's converted in fat cells and liver cells in the periphery. It's not as strong as some of the other estrogens, but it's there throughout life and is there in men as well. E2 is estradiol. It's got di in it for 2, so easy to remember that way. This is the main estrogen before menopause. It's made by the ovaries themselves and is converted again by aromatase enzyme from testosterone. This is by far the strongest one. It's the one that makes a woman a woman. It gives all those female characteristics. So it's much more potent, but when it's gone, women go through menopause, which is why it's so valuable. E3 is estriol. It's got tri in it, TRI. This is mainly produced during pregnancy by the placenta. It's not there at any other time in life for the most part. It's also the weakest or the least strong. So when you think of these, it's 1, 2, 3. And I'm going to be slightly sexist, but I want you to just remember man, woman, child. Makes it a little bit easier. Man, E1, estrone, there even after the ovaries are gone. Not as strong, but there throughout life. 2, woman, estradiol, made by the ovaries, the strongest, the one that gives our female characteristics. And then 3, child, estriol. This is made by the placenta during pregnancy and is the weakest of the 3, the smallest. I want you to look on this chart real quick. We're going to pull it up. We're going to talk about the steroid enzyme production and the pathway that starts with cholesterol, which is where all of our sex hormones come from. So we've got progesterone in the middle of the chart, the testosterone formation, and then conversion by the aromatase enzyme all the way to the different estrogens. If you guys don't have this memorized by now, which I'm sure nobody does, pause, get out a blank sheet of paper, and write this down with all of the enzymes until you have it memorized. This is going to come up again and again and again, both in medical school, residency, and really in private practice as well. You need to know that it's the aromatase enzyme that converts testosterone to estradiol and androstenedione to estrione. You need to know the 5-alpha reductase, which makes testosterone into the stronger dihydrotestosterone. You need to know about the mineralocorticoids and the glucocorticoids and how you get Cushing syndrome and how you get congenital adrenal hyperplasia. So this will come up no matter what field of medicine you go into. Good time to hit pause, write it down. You can do it again when we do our next lecture as well, because it takes a couple times to get through. The other big chart that I want you guys to remember is our hypothalamic pituitary gonadal axis, and specifically for this lecture, the ovary. This is really important as well, not only because you need to know that it's GnRH that comes from the hypothalamus, stimulates the pituitary for the gonadotropins, LH and FSH, which then go down to stimulate the ovary, make testosterone, which is converted to the estrogens, and then go out to the specific tissues in the body where they have their effect. I want you to remember that oral contraceptives feed back and have a downregulating effect on the anterior pituitary, and that clomiphene goes back to the hypothalamus, and that's where it acts. So those are going to be big questions. There's that negative feedback loop where after estrogen and progesterones are made, they go back to both the hypothalamus as well as the anterior pituitary, have their negative feedback, and stop that stimulation from going back to the ovary and making more and more of these hormones. So it's a perfect loop until some of our hormones and chemicals and drugs come in and interrupt that loop. So we're going to get into how that's clinically useful later, but I wanted to pause there and have you think about that. The way that estrogens work is by cellular diffusion into the nucleus. There's two main actions that they have at the nuclear receptor. One is by RNA transcription and protein synthesis, and the other is by direct intracellular second messenger pathways. Effects that they have in nature, well, certainly they're important for female sexual maturation, as well as genital development and secondary sex characteristics. When women have primary hypogonadism or they're not making estrogen and progesterone in their ovaries, then we can give them that to go ahead and simulate that sexual maturation. Cyclically, estrogen is important for the endometrial lining and a lot of the process of follicle development and ovulation. Think about that perfect 28-day theoretical ovarian cycle that women have, where for the first 14 days, that dominant follicle is growing because of FSH stimulation. It's releasing estrogen, which is building and thickening the lining of the endometrium. And then on day 14, there's the LH surge. The ovary releases the egg, and that dominant follicle switches names. Same thing, but now we call it the corpus luteum, which produces progesterone for exactly 2 weeks. For those 2 weeks, the progesterone stabilizes the endometrial lining. It actually counteracts the growth of the estrogen and stops growth, but helps vascularization. And then after 2 weeks, it dies. And when it dies, there's an abrupt cutoff of progesterone and estrogen, and that endometrial lining sheds if there's not a pregnancy there to support it. We're going to talk about that flow a number of other times. But estrogen obviously is important in that first half for building up that endometrial lining. Estrogen is important for skin and teeth function, as well as bones, blood vessels, and it has beneficial effects on lipid profiles. So it decreases total cholesterol, it decreases the bad cholesterol, low-density lipoproteins, and increases HDL, or the good cholesterol, which is the high-density one. Therapeutically, we can use estrogens to give a lot of these same effects. We talked just a minute ago about primary hypogonadism. If for a variety of reasons those ovaries aren't releasing estrogen, we can give estrogen back. And we can still give those secondary sex characteristics or cyclic changes or uterine protection the same way that the body naturally does that on its own. Also, dysfunctional uterine bleeding. So a little bit outside the limits of this lecture, but when women have irregular bleeding, we usually try to characterize it into which half of the cycle is responsible. So is it an estrogen effect where we're not building enough of that padding, of that endometrial lining, so you've got bare exposed blood vessels and walls in the uterus? Or is it a progesterone effect where we're not supporting that lining well enough so it's shedding before it's supposed to? Well, if it's a problem with the estrogen effect, with the building or proliferative phase, the first half of that cycle, then we can give more estrogen and stop that bleeding. Also, contraception, which we're going to talk about in the next lecture, and hormone replacement therapy, which we're going to get into in just a little bit. So how can we give estrogen? Well, back in the 1800s, when they were first studying estrogen, they got this effect by actually taking ovaries from animals and melting them down and getting the estrogen out, and then using that to see what sort of effects it had on women and humans. Obviously, this is a very inefficient way to get natural estrogens because you have to sacrifice those ovaries every time you do that. So the first natural estrogens that we were able to excrete out, and which we're still using, are actually from horse urine. So pregnant mare's estrogen. So you know the name Premarin, so that's pregnant mare, and urine. That's Premarin, and that's where we get all of our natural organic estrogens, which we use in our compounds today, the ones that aren't synthetic. Premarin is a compilation of almost 20 different estrogens, but most of the important ones that are the equine ones, the horse ones, have that EQUI, that equi or equus in front, and that's always your Q for that. Beyond that, we can use synthetic estrogens, which are derived mostly from plants. The two main ones which we use are ethinyl estradiol and mestranol. These are synthetically altered to decrease first pass hepatic metabolism. So when you take an estrogen orally, it gets broken down by the liver, and that happens right away before it gets out to the rest of your peripheral tissue. It's excreted in the bile and then reabsorbed in the enterohepatic system, and then it goes out to the target tissue. Well, that breakdown has two effects in the liver. One is to ramp up the liver and some of the things that it does, like make clotting factors, which we'll talk about in a little bit. The other is to break down that estrogen so that it doesn't last as long and it's not as strong or not as potent. So ethinyl estradiol or mestranol are chemically altered in ways which give them a longer half-life and make them stronger and more potent. There's a bunch of other estrogens that we use. Those are the two biggest ones that you're going to see, especially in oral contraceptives or hormone replacement therapy. If we want to bypass that hepatic metabolism, there's other ways that we can do it. First, we can skip the oral route entirely. We can give estrogens as a vaginal ring or a cream or a gel or spray or a foam. And in the past 5 years, there's really been an explosion of this from the pharmaceutical companies. They've realized that not only can they market something new and get a trade name on it, but also skipping that first pass hepatic metabolism gives them a stronger agent that lasts longer and is more powerful, and also avoids some of those detrimental effects of stimulating the liver.
Okay, now let's pause for a moment and review the material that was just covered. Before we do that, if you haven't already done so, this might be a good time for you to read your pharmacology text that corresponds to the material that was just discussed. Then together, we're going to go through the quick review in your study guide. Let's go through the answers to quick review number 1. Number 1, which hormones are made by the aromatase enzyme? So aromatase is going to convert androstenedione to estrone, and it's going to convert testosterone to estradiol. Those are two important reactions to know that are catalyzed by aromatase. Number 2, how do the effects of estrogen relate to its therapeutic uses? So we talked about the estrogenic effects, and those estrogenic effects are useful clinically for certain scenarios. So one of the effects we discussed of estrogen was female sexual maturation, like breast development and fat distribution, and also female genital development. So this is going to be particularly useful in cases of hypogonadism. All that means, hypogonadism, is low estrogen. And in males it means low testosterone, but this is female hypogonadism that we're talking about here. The next one, endometrial lining growth and follicle development. So this is stabilization of the endometrium, and this is going to be particularly useful for dysfunctional uterine bleeding. Feedback inhibition of luteinizing hormone and FSH. When would you want that? Contraception. All right, so if you want to prevent ovulation to provide for contraception, this is a scenario where you would use estrogen for this effect. Maintains healthy skin and teeth. So healthy skin in particular is going to be important for a condition called atrophic vaginitis. This is a condition after menopause where you have low estrogen levels, and it causes thinning of the vaginal tissue, and that can be very irritating, can cause some bleeding in the area, and sometimes can also be associated with urinary incontinence. So some estrogen cream to that area is going to maintain that healthy skin there in that area and help resolve atrophic vaginitis. Maintaining bone strength. So estrogen is a potential treatment or a potential component for the treatment of osteoporosis. Now, your bread and butter osteoporosis treatment is bisphosphonates, but in women sometimes you might use estrogen as well. Maintains blood vessels. So this is going to be useful in the reduction of hot flashes, the vasomotor response of the hot flashes, vasomotor symptoms in menopausal patients. Going to be reduced with estrogen supplementation. And the last one here, improves cholesterol, higher HDL and lower LDL. So this is the reason why it used to be the case that all postmenopausal women we tried to get on hormone replacement therapy, because we thought by improving this cholesterol profile, you're going to reduce cardiovascular risks. It turns out that correlation doesn't exactly exist, and we don't give estrogen now for cardiovascular risk reduction, although it does have this favorable lipid profile. So we don't really use it for this indication anymore. Moving on, number 3. What are some of the more testable causes of hypogonadism? So we've mentioned hypogonadism a few times, specifically here female hypogonadism or estrogen hypogonadism. So what are some of the causes? There's two main classifications of hypogonadism. There's hypergonadotropic hypogonadism and hypogonadotropic hypogonadism. So with the hypergonadotropic is referring to is high luteinizing hormone and high FSH, follicle stimulating hormone. And so with hypergonadotrophic hypogonadism, this is an indicative of ovarian dysfunction. So your ovaries are not working. You have all the luteinizing hormone and follicle stimulating hormone around to be able to stimulate the ovaries, but they're not being stimulated to mature a follicle and produce estradiol, right? So when would you get this? Of course, menopause. And if you have menopause too early, before age 40, that's premature ovarian failure. So those are two conditions where you're hypergonadotrophic and you have hypogonadism. Turner syndrome is another one of those causes of this. There's ovarian dysgenesis as a component of Turner syndrome. And then 17-hydroxylase deficiency as well. Is this important for your pharm test? Probably not, but I think it's good pathophysiology to throw into this pharm component. Now let's talk about hypogonadotropic hypogonadism. This is where you have low LH and low FSH. This is going to result from your hypothalamic and pituitary dysfunction. So your ovaries are working fine, but you don't have enough FSH and LH to stimulate the ovaries to do anything. So Kallmann syndrome is an example of this. This is where you have an absence of GnRH release, gonadotropic releasing hormone release is deficient. And one of the high-yield little things associated with this is anosmia, or an inability to smell. So if you see estrogen deficiency in a patient that's not able to smell things, that would be Kallmann syndrome on your test. Sheehan syndrome is associated with postpartum hypopituitarism. So this is where you have pituitary infarction in a patient that has just delivered, usually because of excess blood loss, and then you have poor perfusion of the pituitary, and so now your pituitary is not making FSH and LH very well, and that causes your hypogonadism. Hyperprolactinemia can cause hypogonadotropic hypogonadism. So one of the common causes of hyperprolactinemia is a prolactin-secreting pituitary adenoma. And another common cause of hyperprolactinemia is the supplementation with a dopamine antagonist. Classically, these are your antipsychotics like haloperidol. And then one I think it's also important to know is anorexia nervosa can also cause this low level of estrogen because of low levels of LH and FSH. Number 4, what stimulates the ovarian follicle to produce estradiol? This is FSH. Number 5, what effect do high levels of estrogen and progesterone have on LH and FSH? They inhibit the production of LH and FSH. This is your negative feedback inhibition. It's a very important component to remember in terms of the pathophysiology of several disease states. And then number 6, what is the more potent manner in which to dose estrogen? By oral pill or transdermal patch? So the transdermal patch is going to be the more potent way to dose your estrogen. And the reason why is because when you absorb the drug through the skin, where does it go? It goes into the venous capillaries, and that goes from your venous capillaries, it goes back to your heart, right? It's not necessarily going to your liver. So you're bypassing that first pass liver metabolism, which means you can get the drug to the rest of your body much earlier, and you don't need as much of the drug on board to hit the rest of your body. So you need a lower dose of estrogen, and a lower dose of any drug means that that drug is more potent. So transdermal patch is more potent than oral pill. Now, there is one other thing that I want to mention here while I have your attention. It can be very confusing for a student to try to compartmentalize in your brain the differences between estrogen, progesterone, oral contraceptive pills, and hormone replacement therapy. So I want to give you a framework of organization that's really going to help you. All right, so you need to know about estrogen and what it does, and that's what we've just discussed. So know estrogen in and of itself. Know progesterone in and of itself, and we're going to talk about that in the next lecture. I want you to think of oral contraceptive pills as a combination of medium dose estrogen and progesterone. So when you think of oral contraception, think medium dose estrogen and medium dose progesterone. What is it going to do? We're going to talk about that in the next lecture. When you think about hormone replacement therapy, think about low dose estrogen, right? So the dose of estrogen and hormone replacement is lower than that of oral contraceptive pills. And we'll discuss some of the ins and outs of that in a little bit. So that's important to know. Now you might be thinking, well, what has high dose estrogen? In the literature, you're going to see high-dose estrogen as a term that's referred to in pathological states. A lot of there's an ovarian tumor that elaborates too much estrogen, so you would be exposed to way too much estrogen in that scenario. And then also, when oral contraceptive pills first came out, the doses of estrogen in those pills were very high, and so there's a lot of side effects associated with that. So usually, whenever you see the term high-dose estrogen, you're referring either to a pathological state or to one of those earlier versions of oral contraceptive pills that's associated with a lot more of those estrogenic side effects. So hopefully that clarifies some of that organization in your mind.
So that's it for this quick review. Let's get back to your main lecturer.
So let's talk about menopause and how we use these in clinical practice, because these estrogens are essential to get a lot of beneficial effects once women go through menopause and aren't putting out that estradiol from the ovaries that's been so important. Every woman's born with as many follicles and eggs as she's ever going to have. In fact, it's even more before she's born than by the time she comes out of her mother at the time of her birth. Those follicles and eggs slowly die off each month. Each cycle, thousands and thousands of them get depleted, born with millions. As that happens, that ovarian reserve gets less and less. So when that FSH and LH and gonadotropin stimulation comes from the pituitary to the ovaries, it has to push harder and harder as women age to get that dominant follicle development, to get that estrogen release for that negative feedback and slow it down. So you'll see a rise in that FSH as a woman gets closer to menopause, which we test for. And then eventually, generally around the age of 51 and a half, that's the average age of menopause, that estrogen is deplete. We still have that estrone from peripheral conversion of testosterones, but we don't have that estradiol, which is so much stronger. So we have a lot of classic signs and symptoms of menopause. Certainly the one you hear the most about are hot flashes, which we call vasomotor symptoms. Women have sleep disturbances or trouble getting to sleep or staying asleep. Urogenital atrophy, remembering that the bladder and the vagina both come from similar tissue and they're both estrogen dependent. So not only do women have problems with decreased vaginal lubrication or pain with intercourse, which we call dyspareunia, but they also have more urinary tract infections, and then sometimes more problems with urinary incontinence. There can be changes in skin, teeth as well. There can be some issues with memory loss, especially anomia or having trouble remembering the names of words. And then there's some asymptomatic effects as well. Osteoporosis is certainly the most prevalent, the one that we think about the most. Estrogen is very important for bone health maintenance, so there's accelerated bone loss after a woman goes through menopause. There's lipid changes. Again, we're losing that beneficial effect. Cholesterol goes up, LDL goes up, and HDL goes down. And then there's a loss of cardioprotection. So we know that women of a certain age group have less cardiac events than men of that same age. And there's some theory that estrogen is a big part of that. Maybe the cholesterol is part of it, but they lose that when they go through menopause. And women rapidly catch up or sometimes even surpass men in some of these cardiac health issues after menopause. So we can reverse a lot of this by giving estrogen through any of the means that we've talked about. We can help bones, we can help sleep, we can help that dyspareunia or urinary incontinence or the hot flashes and the vasomotor symptoms. So if we've got those benefits and this potential cardioprotective side benefit, why wouldn't we just give estrogen to everybody? Well, that's something that we tried actually. About a little over 10 years ago, there was a big study called the Women's Health Initiative. They took tens of thousands of women and randomized them to either getting estrogen with or without progesterone or not. And they gave these really high doses of this great drug to women who hadn't had it in a really long time, so they must have really needed it. And they were going to give them all this cardioprotection, and heart attacks and stroke were going to go down. So this was majorly funded, hundreds of millions of dollars, took many, many years. And unfortunately, we found exactly the opposite. There was more heart attacks, there were more strokes, there was more blood clots, there was more breast cancer. And so there was this big pullback, and this whole idea of estrogen as a cardioprotective agent was blown out of the water. we've learned a lot since that time, and I think it breaks down to three main lessons that we learned about estrogen and how we should use it clinically. And these have to do with indication, with timing, and with dosage. So let's talk about dosage first. For all those asymptomatic effects that we talked about, the bone health, the cholesterol, it doesn't really matter how much estrogen you give. There's going to be bone protection with estrogen even at the smallest dose, no matter how you give it, whether you give it vaginally or whether you give it as a patch or a pill. And the same is pretty much true for cholesterol, within reason. So really, we want to use the lowest dose that we need to treat the symptoms that we're trying to treat. So if a woman has hot flashes and we can get away with dose X to make her hot flashes go away, we'll get all these other benefits for skin and teeth, potentially even memory, certainly for bone health. So lowest dose, as opposed to this study where they took these really big doses, much bigger than we're using today, although still much smaller than oral contraceptives. Remember, there's a big gap. Oral contraceptives are much, much higher than hormone replacement therapy because, again, with really small doses, you get really big effects. The second thing is in timing. So the average age of women in this study was more than 10 years out from menopause. So they had these 68 and 72-year-old women, hadn't been exposed to estrogen sometimes in 15 or 20 years, gave them these big doses. And we know that estrogen in the liver ramps up those clotting enzymes and can increase thrombus, deep venous thrombosis, pulmonary embolism, can cause heart attacks and strokes, increase blood pressure. So big doses in women who aren't used to it cause problems. But there's great evidence out there that if you use it in the first 5 years after menopause, you don't get any rise in those issues. So we try to start a hormone replacement right away. And then generally the recommendation is to stop as soon as you can. So the lowest dose for the shortest amount of time to treat symptoms. We really haven't had a great study yet that looks at women started right at menopause and follows them 20 years to see if that cardioprotection then holds. That hasn't been done yet. So in your careers, we'll get the answer to that, I'm sure. But for the time being, lowest dose, shortest amount of time to treat symptoms, which is this last part about indications. The two main indications for estrogen hormone replacement therapy are vasomotor symptoms and hot flashes and vaginal dryness or dyspareunia, pelvic pain. That's because everything else can be treated in other ways. So if you've got osteoporosis, you can treat that with a bisphosphonate. If you've got high cholesterol, you can treat that with a statin. If you have vasomotor symptoms even, sometimes there's second line things, like we can treat that with Effexor or some of the antidepressants, as well as clonidine, which is an antihypertensive. Sometimes we use a patch for that, but those don't work nearly as well, only about half as well as estrogen itself. So the two primary indications are dyspareunia and vasomotor symptoms. You do get all those secondary benefits, but if you have any of the other problems, you really should be using a different agent because of those side effects that we found from the Women's Health Initiative. How can we give it? Well, certainly we can give estrogen as a pill that somebody takes orally. I told you that there's so many different creams and foams and gels and patches and different ways to give it transdermally now. Also, we can give it vaginally. There's also pills and creams and gels that, as well as rings, polymer rings that are introduced vaginally. And if you're treating urogenital atrophy, that's definitely the best way to do it. It's going to have a much stronger local effect and give them much more of what they're looking for. It still has systemic effect. So don't be fooled into thinking that just because you treat a local symptom locally, that's not potentially going to increase the risk for clots. It will. But with any of those transdermal or transvaginal applications, we're skipping that first pass hepatic metabolism again. So again, that key of potentially decreasing blood clots. And that's really attractive right now, and people are studying that and thinking a lot about it. It does look like there is a decrease that's been proven. In terms of saying it's safe or not safe, we're certainly not there yet, but certainly a big benefit. The only reason progesterone is used in hormone replacement therapy is to protect the uterus. So thinking back again to that 28-day cycle, 14 days of stimulation from that dominant follicle as it's growing, pushing out estrogen, building up that lining inside the uterus, telling it to grow, 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 grow. And then progesterone jumping in for the next 14 days and stabilizing that lining and telling it not to grow, not to divide, not to multiply. So if a woman gets unopposed estrogen, either because you're giving her hormone replacement therapy, estrogen every day with no progesterone, or if she's premenopausal but she's anovulatory, if she never releases that egg, if she stays in that first proliferative stage for 3 months or 6 months or 6 years, that unopposed estrogen is going to keep acting on that endometrial lining and it's going to increase her risk for cancer. That's actually our biggest risk factor for uterine cancer is unopposed estrogen. So if a woman still has her uterus after menopause, we have to give progesterone with the estrogen to protect the uterus from cancer. And if you don't, eventually you're going to have bleeding and you're going to have dysplasia and hyperplasia and cancer. So some of the adverse effects of estrogen replacement, some of the bad things that happen. Well, we talked a little bit about that first pass in the liver, how it ramps up those clotting factors, venous thromboembolism. We will see both premenopausally and postmenopausally, usually in really low numbers though. Premenopausally, if somebody has a clot, when you put her on a birth control pill, she probably has an undiagnosed thrombophilia or hereditary clotting disorder that nobody's found before. It's very rare. We don't need any extra testing before we start women on it, but when you hear about those cases, that's usually the problem. Also, smokers over the age of 35 can have that. Being a smoker obviously increases your risk of a blood clot. Older age does, and so when you combine that with the estrogen, that's going to increase your chance of having a thromboembolism. And then postmenopausally with hormone replacement therapy, high doses in women who are far out from menopause. So again, starting it within 5 years, using the lowest dose to treat the symptoms. Beyond that, we talked about strokes and heart disease. Certainly, I think more than anything, we've learned that there's no cardioprotection from estrogens, or at least certainly not from big doses far out. Now, that stroke and heart disease hasn't been seen in the first 5 years. So again, you're going to hear that it causes stroke and heart disease, but remember that first 5 years is a safe window. So the timing is very important. Endometrial cancer, we talked about if it's unopposed. Dementia, this might be an effect of the strokes that we cause by blood clots. And then breast cancer, I think for the purposes of your test, the answer is that estrogen can cause breast cancer. Because breast cancer, in many cases, is estrogen receptor positive. So it's a little bit tricky clinically. When they did the Women's Health Initiative, they only saw an increase in breast cancer when it was estrogen and progesterone, not in estrogen alone. There also wasn't an increase in deaths, so maybe they were thinking the cancer was there, but the estrogen just stimulated it and made it clinically discoverable sooner. A little tricky, but I think for the purposes of your test, yes. I think for the purposes of your clinical practice, I don't want you to think that if you give a woman birth control pills, you're going to give her breast cancer, because you're not, and that is certainly very well proven. Absolute contraindications. Well, severe cardiac disease, strokes, heart attacks, blood clots in the past. We talked about smokers over the age of 35. Obviously, that's more premenopausal. Estrogen receptor positive cancers like endometrial cancer or estrogen receptor positive breast cancer. Generally, if a woman has liver cancer, we don't give estrogens because of that thought that it upregulates the liver. I don't know that that direct correlation's been established, but it certainly makes sense. Not with a known pregnancy. So certainly you want to do a pregnancy test anytime before starting a fertile woman on a birth control pill, but many women get pregnant on birth control pills and there's no proven downside to that or side effects to that. I think more than 5 years after menopause is probably a contraindication. I know some clinicians who will in certain circumstances, but you're getting outside of that proven safety range. Migraines with an aura. So a woman who has headaches described as migraines, that 30 minutes or 60 minutes or 2 hours ahead of time she has reliable and reproducible auditory or visual changes each time. And we know that women who have migraines with aura are an increased stroke risk already, so the estrogen combined with that it just intensifies that even more. And then undiagnosed bleeding, this goes along the lines of that endometrial cancer risk, so you certainly want to work up any irregular or heavy menstrual bleeding before starting somebody on an estrogen, especially a postmenopausal woman.
Okay, now let's pause for a moment and review the material that was just covered. Before we do that, if you haven't already done so, this might be a good time for you to read your pharmacology text that corresponds to the material that was just discussed. Then together, we're going to go through the quick review in your study guide.
Why can't you prescribe unopposed estrogens as a hormone replacement for postmenopausal women who still have their uterus? There's a high risk of endometrial cancer with unopposed estrogens, so we use a progestin to reduce the risk. What are you doing? You cannot be finished scrubbing in yet. If I'm still scrubbing, then you're still scrubbing. I've been doing this since you were in Pampers, and there is no way that you can scrub in faster than I can. Now start over.
All right, let's go through the answers to quick review number 2. Number 1, what is the precursor pathology to uterine cancer? Very important to know, very high yield. It is endometrial hyperplasia. Endometrial hyperplasia. And so both, if you give unopposed estrogen to a patient, not only are you going to increase your risk of uterine cancer, you're going to increase your risk of endometrial hyperplasia, which is your precursor lesion to uterine cancer, or endometrial cancer is the same thing. Number 2, what is the biggest risk factor for uterine cancer? Excess estrogen. High estrogen states are the biggest risk factor for uterine cancer. So this includes polycystic ovarian syndrome is a state of excess estrogen. With obesity, you have way too much estrone on board. With Sertoli-Leydig cell tumors of the ovary, this is an ovarian tumor that elaborates way too much estrogen, so that's going to make it more likely for you to have uterine cancer. And then, of course, unopposed estrogen in your hormone replacement therapy. Number 3, what are the most common hereditary thrombophilias that can increase one's risk for DVT and PE when estrogen is given? And so these are worth knowing. These are your factor V Leiden mutation, your prothrombin gene mutation, protein C deficiency or protein S deficiency, and also antithrombin deficiency. So if you have any one of these mutations, you're much more likely to get a DVT and pulmonary embolism either with or without estrogen. And if you throw estrogen into that, it's going to increase your risk even higher. Number 4, is hormone replacement therapy contraindicated in smokers over age 35? The answer to this is no. Oral contraceptive pills are contraindicated in smokers over age 35. But remember what we talked about earlier, how the dose of estrogen and oral contraceptive pills is higher than that of hormone replacement therapy. So in smokers over age 35, you can't give OCPs. You can give hormone replacement therapy, though, to treat menopausal symptoms. Will that increase the risk of DVTs? Yes, it will, but not as much as giving oral contraceptive pills would. Number 5, a 55-year-old female comes to her physician to discuss menopause because all of her friends are complaining about it. She is not having menopausal symptoms and is still having monthly cycles. She continues to take the combination oral contraceptive pill that she has taken since age 35. What would the physician do for this patient? What should the physician do for this patient? So what's going on here, she's taking her OCPs way too long. She doesn't need to be taking that into her 50s. So she's probably been taking her oral contraceptive pills throughout her first few years of menopause. She maybe hit her menopausal years at age 50, and for the last 5 years she's been taking her OCP, so she has no idea. Is she continuing to have monthly cycles? Yes, she is, because the OCPs are giving her monthly cycles. She probably no longer needs birth control, right, because she's probably menopausal. So in this scenario, at the very least, the patient needs to be switched from oral contraceptive pills to hormone replacement therapy. So just to be clear, the patient that is menopausal or postmenopausal that is on OCPs needs to be switched to hormone replacement therapy at the very least. And the reason why is because OCPs have much more estrogen than what is needed. And remember, we need to keep the dose of estrogen at the lowest dose possible to achieve the desired effect. And the desired effect here is to reduce menopausal symptoms. A more conservative option in this patient would just be to discontinue the oral contraceptive pills and see what happens. It may be the case that you stop the pills and she doesn't really have very severe menopausal symptoms. And if that's the case, you probably don't need to give her hormone replacement therapy. Number 6, how should the clinical use of OCPs and HRT be adjusted with respect to breast cancer risk? So, as mentioned earlier, OCPs, oral contraceptive pills, do not increase the risk of breast cancer. Studies have shown that there's no correlation between OCP use and breast cancer risk. So you don't need to worry about it from that standpoint. But just to be conservative, we say that any patient that has had a history of breast cancer should not be on OCPs, especially if it's an estrogen receptor positive breast cancer. So that is definitely the case. Hormone replacement therapy may very slightly increase the risk of invasive breast cancer, but only slightly. It does not increase the risk of non-invasive breast cancer, though. So similar type of thing. You don't really need to worry about the risk so much until a patient has breast cancer. And in any patient that has a history of breast cancer, we do not give hormonal HRT, hormone replacement therapy. Number 7, a 50-year-old female comes to your clinic for treatment of menopausal symptoms. During the history, she states that she has been having some vaginal spotting about every 2 weeks for the last few months. What workup needs to be done prior to prescribing hormone replacement therapy? So in this instance, you have a patient that is having some vaginal bleeding, some vaginal spotting. You don't know why. And so at the very least, you need to get an endometrial biopsy. Very simple procedure. It takes about the same amount of time as a pap smear. Just use a very small straw-like papel to obtain a sample of the endometrial tissue. It can be done in the clinic, and it's something that needs to be done before hormone replacement therapy is prescribed, because it could be the case that this patient either has endometrial hyperplasia or uterine cancer. You need to rule that out in this patient with abnormal uterine bleeding that is in the menopausal period.
So that's it for this quick review. Let's get back to your main lecturer.
So we talked at the beginning a little bit about selective estrogen receptor modulators, or SERMs. That's our next subject. These are drugs that have some estrogenic activity and some anti-estrogenic activity. The problem is it's different in every tissue, and it's different for each of the drugs. So we're going to go over these kind of clinically. I think that's going to help you remember the important parts of one versus the other. There's 4 of them, at least, that are widespread in clinical use, probably only 4 that you need to know for your test. And they do act with estrogen receptors much the same way that estrogen does, but again, either upregulating or downregulating, specific for the tissue. So the first of these is tamoxifen. This is sort of famous for its treatment of breast cancer because it's an anti-estrogen in the breast. So if you have a patient who's estrogen receptor positive breast cancer, this is a great agent for either chemoprevention or preventing recurrences. If she's not estrogen receptor positive, this isn't going to help her at all, obviously. It's a partial agonist for estrogen in the uterus. So the upside is you decrease breast cancer. The downside is you stimulate that uterus, potentially with that unopposed estrogen. And so we only use it for about 5 years, because after that we're just not sure that it's safe for not causing uterine cancer, which if you use it long enough, it will. It causes hot flashes and nausea and sometimes some abnormal bleeding even outside of cancer. The main thing is the hot flashes. You'll see that in the vast majority of the patients who take this. And then certainly that endometrial hyperplasia that we talked about. There's a similar medicine. The second one on your list is terimifene. This is almost exactly like tamoxifen, but a little bit less studied, and so we use it a little bit less often. It's also a partial antagonist in breast tissue, so it's estrogen receptor positive breast cancer. There's less evidence on endometrial hyperplasia or endometrial cancer, and so it's not as widely used. If you do have tamoxifen resistance, you cannot use this because it works exactly the same. So we've got another drug coming up when women become resistant to tamoxifen, but this won't work for that because it's the exact same mechanism of action. Raloxifene is used for the treatment of osteoporosis. It's an estrogen agonist in the bone, so it decreases bone resorption or bone breakdown, which gives a net effect of bone growth. Doesn't actually cause growth, but the net effect is an increase because there's less breakdown. It has been proven to decrease breast cancer as well. It is an antagonist in breast tissue. It's really good, actually, but it's not quite as good as tamoxifen. So tamoxifen's still first line for that, and that's not one of the necessarily recommended uses, but it has no effect, or at least very little, on the endometrium. So sometimes oncologists will choose this for women who's a very high risk for uterine cancer, endometrial cancer, because they don't have to run that uterine cancer risk, but still get that great effect for decreasing breast cancer, and then that bone protection as well. And then clomiphene is a partial agonist at the level of the hypothalamus, and it's used for ovulation induction. This is a little bit tricky because it's an agonist, but it actually works differently from the estrogen. So thinking back to that chart that we looked at before with the hypothalamic pituitary ovarian axis, when estrogen's made by the ovaries, it feeds back up to the hypothalamus as well as the anterior pituitary and tells them to stop pumping out those hormones and stop giving the ovaries stimulation. Well, if we use a medicine to fill up those receptors, to competitively inhibit those receptors, even if it's doing the same thing, if it's not doing it as strongly, the net effect is going to be a decrease in that negative feedback. So there's going to be more stimulation going down to the ovaries. So essentially, this medicine, clomiphene, is cutting off that negative feedback loop, preventing the estrogen from stopping the feedback, so more and more and more stimulation gets pumped to the ovaries, and that helps that dominant follicle grow and release that egg, which it might not otherwise be doing in an anovulatory woman. So that's how we use that. Again, nausea, headaches, hot flashes. Probably 85% of women who use this get hot flashes, so a very predictable side effect for that. There's two anti-estrogens. One is a direct anti-estrogen that blocks the receptors. The others decrease the creation of estrogens by stopping the aromatase enzyme. So the first one that we're talking about is fulvestrant, which is a pure estrogen receptor antagonist. So as opposed to our SERMs, or selective estrogen receptor modulators, which are partial antagonists but competitive inhibitors and can be overcome, this blocks and doesn't release. So it actually completely shuts off the ability of estrogen to bind to those receptors and cause its effect. We use this in women who develop a resistance to tamoxifen in breast cancer, and you can because it's like the next step down the line. So the mechanism of action is similar, but much more significant. So it still has benefit. The second category are these drugs that are aromatase enzyme inhibitors. And these break down into two categories. One category is reversible or competitive inhibition, and the other is permanent or irreversible. The first category are anastrozole and letrozole, which is the more potent of the two. Again, those are reversible. The second is exemstane, which is what we call a suicide permanent bonder. So once it attaches, it doesn't release. And then those aromatase enzymes are dysfunctional, and you actually have to make new ones to overcome that and make the estrogen. So if you use enough of it, you'll completely shut off a woman's estrogen production completely. So finally, we're going to finish up talking about GnRH agonists. This gets back into that kind of tricky situation that we had with clomiphene, because a GnRH agonist you would think would pump the pituitary and have it put out more of the gonadotropins like LH and FSH, but it's exactly the opposite depending on how we give it. So remember that the hypothalamus secretes GnRH in a pulsatile manner, and it's that pulsatile clockwork stimulation that gets the pituitary to put out the FSH and LH. If you give it continuously, the first thing that's going to happen is you're going to get a big surge as the pituitary gets hit, and then that gonadotropin stimulation is going to cut off completely and drop women to postmenopausal levels. These are really strong drugs, about 50 to 100 times stronger than the body's natural GnR rate, so they completely take over. That's why you get that big surge. The two are leuprolide and goserelin. And because they're so strong and because they fully put a woman into menopause, they cause a lot of those same menopausal symptoms of hot flashes or urogenital atrophy. Osteoporosis is a big concern, so we only use these medicines for 3 to 6 months. But we can decrease a lot of the side effects by adding back some estrogen. And there's great studies to show that the beneficial effects, we use these a lot of times for decreasing the size of fibroids or pelvic pain with endometriosis. And that beneficial effect of knocking out that pelvic pain continues even with the estrogen add back. So I would say clinically for the majority of our patients, we go ahead and start that add back straight from the beginning. These are also used for breast cancer and prostate cancer and rarely for dysfunctional uterine bleeding.
Okay, now let's pause for a moment and review the material that was just covered. Before we do that, if you haven't already done so, this might be a good time for you to read your pharmacology text that corresponds to the material that was just discussed. Then together, we're going to go through the quick review in your study guide.
Welcome to Stepping Up with me, Richard Sammons. Woo, woo. Step up, you. Work those arms, people. Wave those hands like a Polaroid picture. Oh, great job, people. Now let's take a little breather, stretch it out, and answer me this. Which selective estrogen receptor modulator is used to treat breast cancer? Tamoxifen, and also occasionally toremifene. And which one is used to treat osteoporosis? Relaxafine! You know what helps prevent osteoporosis altogether? Exercise! Now let's get to it and shake it like it hot. Step up.
All right, let's go through the answers to quick review number 3. Number 1, a 40-year-old black female with menorrhagia due to uterine fibroids is placed on leuprolide. She comes to the clinic complaining of severe hot flashes. What is the treatment for this patient? So if you're going to use so in this patient, basically what you've done is you've given them leuprolide in a continuous fashion, and so you're suppressing FSH and LH production, and as a result, your ovary here is not making any estrogen. So you are basically pharmacologically inducing a menopausal state. How do we treat menopause? We give estrogen. So this is called add-back therapy. So we're adding back estrogen to this patient to reduce the symptomatic hot flashes. Number 2, 72-year-old thin white female is being treated with a bisphosphonate and raloxifene. What is she at increased risk for because of the raloxifene? All right, so raloxifene, very important to remember, does not increase the risk of uterine cancer like tamoxifen does. So don't confuse the two. Tamoxifen increases the risk of uterine cancer, raloxifene does not. There is an increased risk of venous thromboembolism, though, such as a DVT or pulmonary embolism while on raloxifene. So that would be the main side effect to be aware of. Number 3, in treating a patient with osteoporosis with an estrogenic agent, what are the advantages of using raloxifene rather than conjugated estrogen? So raloxifene is going to have the benefit of being an antagonist at breast tissue, so actually reduce the risk of breast cancer. And raloxifene is also going to have the added benefit of not stimulating the endometrium. So your raloxifene will not increase your risk of endometrial cancer or uterine cancer like conjugated estrogen would. Number 4, what is the drug of choice for infertility treatment due to anovulatory cycles? This is clomiphene. So clomiphene is a very commonly used drug. The next question, how exactly does clomiphene work? So this can be very confusing because clomiphene is described as a partial estrogen agonist at the hypothalamus. And so we know that estrogen binding at the hypothalamus causes a negative feedback inhibition that's going to decrease the release of luteinizing hormone and follicle stimulating hormone. So why is it the case that a partial agonist binding to the hypothalamus is actually increasing follicle stimulating hormone, when usually when we talk about estrogen binding to the hypothalamus, it causes negative feedback inhibition? The key here is that clomiphene is a partial agonist. So it is not stimulating the hypothalamus, it is not affecting the hypothalamus as estrogen would. And instead, it's blocking that estrogen receptor at the hypothalamus. So the result of this is that estrogen can't get to the hypothalamus because clomiphene is blocking that receptor. And as a result of this, you're removing the negative feedback inhibition that would have been present with endogenous estrogen. So let's just recap this. So normally you have endogenous estrogen that comes back up to the hypothalamus and causes negative feedback inhibition that causes a decrease of luteinizing hormone and follicle stimulating hormone. Well, if you block those hypothalamic receptors to estrogen with clomiphene, then estrogen doesn't have that negative feedback inhibition anymore, and that allows luteinizing hormone and follicle stimulating hormone to be stimulated by gonadotropic releasing hormone. So basically, clomiphene results in less negative feedback inhibition of endogenous estrogen because it is a partial estrogen agonist at the hypothalamus. Number 6, a 40-year-old female undergoes surgery for the resection of breast cancer. Pathologic analysis of the tumor reveals that it is an estrogen receptor positive tumor. What medication will this patient probably have to take? So of the medications we've just discussed, tamoxifen would be the drug of choice.
Okay, so now's a good time to pause the video and complete your in-session quiz, then restart the video and we'll go through the quiz together.
Hi, I'm Dr. Chris Lewis. I'm here for your in-session quiz for estrogen and hormone replacement therapy. Let's get started. Why is a patient's past surgical history an important consideration when determining postmenopausal hormone replacement therapy needs? Well, if a woman has had a hysterectomy, then estrogen-only replacement therapy is appropriate. Now, why wouldn't you want to give estrogen-only therapy to someone who has a uterus? Well, the reason behind that is that you don't want to give them uterine cancer, so that's a big deal. So you always want to know, does a woman have a uterus or doesn't she? Next, for what duration is tamoxifen dosing limited due to an increased risk of uterine cancer? Well, that's 5 years. What SERM, or selective estrogen receptor modulator, used to prevent breast cancer may not increase the risk of endometrial cancer? Well, that's raloxifene. What enzyme is essential for the generation of estrogen? That's aromatase. What is the therapeutic use of each of the following agents? So let's go through these. First one is leuprolide. Now you want to use this for breast cancer, prostate cancer, and uterine bleeding. Clomiphene. This is to induce ovulation. Tamoxifen. This is a receptor, an estrogen receptor positive breast cancer drug. And then ethinyl estradiol. This is used for urogenital atrophy, vasomotor symptoms, and it's also used in combination hormonal contraceptive methods. What are the signs and symptoms that HRT aims to alleviate? Well, first is vasomotor symptoms, next is urogenital atrophy, and last is osteoporosis. Now, would we add prevention of cardiovascular events? No, it's actually the opposite. What are the adverse effects associated with estrogen therapy? Thromboembolus, strokes and heart disease, endometrial cancer, and dementia. Which drugs are classified as selective estrogen receptor modulators, and how do they work? Well, first is tamoxifen, and it's a partial antagonist at the breast tissue. Raloxifene is very similar. It's also a partial antagonist at breast tissue. Tormophene is an agonist in the bone, and it's, again, like the other two, an antagonist in breast tissue. And then clomiphene is a partial agonist at the hypothalamus, not in the breast tissue. What changes are seen in serum estrogen, LH, and FSH after the onset of menopause? Well, your estrogen is going to drop significantly, and especially estradiol is what drops. And then you're going to get increases in LH and FSH. How does the body synthesize estradiol from cholesterol? Well, this is a bit of a process. It starts with cholesterol, it then gets converted to pregnenolone, and then that gets converted to progesterone. And this is using 3-beta-hydroxydehydrogenase. This gets converted to 17-hydroxypregnenolone. And this goes then to androstenedione, and this moves to testosterone. Now finally, testosterone gets transformed into estradiol using aromatase. And that's the end of our in-session quiz for the pharmacology lecture on estrogens and hormonal replacement therapy.